Thank you, Susmita and Purvansha, for this invite. And before I start, I would like to place on record the great work Somshila ma'am and their entire team is doing in spite of all odds. I think we really respect what you've been doing. I think many times these things goes unnoticed, and I did mention also phenomenal work. And thank you, ma'am. And nice to see Bharati ma'am also. So basically, the whole talk is today about corneal biomechanics and its implication in refractive surgery. These are my financial interests. I do work for Oculus where as a research person, but no financial interest with them. I'm going to concentrate more on one device which we all have, rather than trying to bring in concepts which is still not evolved, or something which is kind of obsolete, like an ORA at this point of time. So the Corvus ST is what we use. It has, and to make it very simple, and rather than going to all this mathematical thing, it just looks at how the cornea deforms. And all the deformation factors have been put into a mathematical algorithm. And that's when you get all these values, which probably is given by these 5 indices. And ultimately it ends with this CBI. So what it contains is deformation amplitude ratio. The definition is out here. Integrated ratio, basically the radius of curvature of how much cornea becomes concave. Ambrosio's relation thickness. This is one of the indices with the CBI uses. And stiffness parameter, according to me, this is one of the most important parameters, more than the deformation amplitude or ratio, SPA1. This has been, even though it's not something which commonly used, but it's one of the favorite ones, because anything can see that anything close to 100 or above 100 is good, and anything below 100
and part-time occlusive was running also. Data analyzed where visual acuity, near vision contrast and were done.
Excuse me, there is some disturbance, please.
For higher positioning.
Coordinators, can you please look into it? There is some disturbance.
Okay. So,
one timer, please mute.
And so what we do is we have this indices, the CBI, TBI, and the BAD-D, which CBI comes primarily from your Corvus. TBI is a mix of Corvus and other topography indices. This is paper, most of it has been published by Renato and his group. You can see that the sensitivity and specificity of it is quite high. The only caveat here is that it is not being tested on Asian eyes, and this data is all Caucasian or South American eyes. So we have to take this in a little bit serious note, because the data is not tuned to our population. SSI, the stress strain index, is something new. Ahmad El-Sheikh is the one who described this. This is a new indices which is not really bothered with your intraocular pressure and other parameters, which is heavily dependent when you're looking at the other parameters of the Corvus. The SSI index, anything above 1 is supposed to be good, and anything less than 1 is not so good. So anything less than 0.5 is very, very suspicious. But again, remember this part. This is the normative database where patients with 50 years and above. When you are a 50-year-old person, your cornea is anyway stronger. So they have used maybe an upper limit of a 50-year-old normative cornea. So it is again a challenge sometimes when you make a sense of this indices. But however, it has a different, now a different feature where you call it comparison displays. Every time they come out with a newer indices, for example, this is a cornea which is softer. Imagine if there is a change in your surgery, post-surgery. For example, you've done a cross-link and after 1 or 2 years you do the procedure. If it's actually becoming stiffer, it will compare and tell you it's becoming stiffer. Or sometimes if you do a LASIK surgery and the cornea is actually stiffer and suddenly becomes softer, or suddenly it's becoming softer and softer in terms of these changes, you know that its chance of risk is there for ectasia. So these comparison reports are very new. which is built in the software. And also you get this picture, the red and blue is the pre and post ops, or red is more weaker, the blue is more stronger. So you know the difference maps of these scans. And you can see that it's becoming stiffer, that is between A and B. Imagine this is a cross-linked dye, or you've done a LASIK or a PRK extra, and it's becoming stronger, and that's what this gives. But there are a few challenges out here. It's a permutation and combination issue. If you're using only topography, like Somshila ma'am described so many beautiful cases, when you are in yellow, you know that you're suspicious. When you're green, you're okay. When you're red, you'll stop. When you use a biomechanics, you completely different ball game, because sometimes it matches with your bad D pentacams, sometimes it does not. Sometimes the whole topography is suspicious, the biomechanics is not suspicious. This is one of the main reasons why people stopped liking biomechanics, because it confuses them. The question is, has biomechanics failed, or we have not understood that whole mathematical or a physical or a physiological part of the cornea? It's both. So let's look at cornea. It's a viscoelastic response, the hydration, intraocular pressure, repeatability of scans, quality of scans, length of scans. These are all parameters which makes your biomechanics a perfect tool for you to understand. But I use this in all my presentation. Biomechanics is like the 6 blind men and an elephant. Each of us are picking up one part of that elephant and saying that, well, I know this is a parameter which makes me to suspect or not to suspect. And I think that's where we go wrong, because the true picture may be completely different. I have some 4 cases. If time permits, I'll present all of them. The case 1, the corneal topographer and biomechanics. Look at this. There is an inferior stapling. Most of it is clear. The bad D is yellow. The CBI and the TBI, which is supposed to tell you if it's a suspicion, is completely normal. Now the challenge comes is, and your SSI, like I said, is closer to 1, it's decent. Now, do I need to imagine this is a 20-year-old person, minus 3 diopters? Do we need to go for it? There is a superior inferior asymmetry. On bad D is also abnormal. Now, this is where biomechanics people get confusing. They say that, well, it's not teaching me, and it's not showing me anything more, it's confusing me. But if you add, let's look at the same blind man and an elephant concept. If I had only this, I'm blind, I'm only looking at these 2 things, then I'm confused. If I add an epithelial map, you realize that there's a complete inferior hypertrophy of epithelium, which corresponds to this 60 microns and 49 microns out here. That means around 10 to 12 microns corresponds to a diopter and half. That means this patient is actually, the biomechanics is telling the truth, because it's telling you it's a completely healthy eye. Don't go by the bad D, because bad D is heavily influenced by your asymmetry, your elevations, and multiple things. We don't know. It's an AI kind of semi-AI kind of based metrics. And this is your epithelium, which is a culprit here. So you can easily go ahead and do it. But if I don't have epithelial maps, then I'll be confused. Sometimes we have to mix and match everything. The case 2 is again a confusing map, because your bad D is abnormal. Your TBI, which is derived primarily from your topography and the biomechanics, is on the borderline. And your CBI is completely normal. And look at this. Other eye, everything is normal. And even though the bad D is little on suspicion. Now, this is a very confusing case. And this is what makes people suddenly believe that, do we really understand what biomechanical parameters are? Because this permutation and combination confuses you. Again, look at the epithelial maps. Nothing grossly abnormal in those epithelial maps. There's some central things, but it is not like the previous one. So it doesn't look like an epithelial issue. So this is where Somshila ma'am was kind enough to bring this concept of collagen imaging. We built our own, in our lab, optics lab, the polarization sensitive OCT. We used help from people from Vienna. They are the pioneers in optics. And now we have started imaging the collagen. This is like This imaging the collagen exactly like, imagine, many years back we had the GDX for glaucoma diagnostics. It uses the birefringence principles. It uses the same principle. The one on your handwritten one is your electron microscopy picture of your collagen, how the collagen structures are, peripheral structures are tightly wound and the centrals are different. You can see that here also you can see exactly the same structure. The red areas are, these areas are different, red areas are different, and the central ones, darker blues means you have highly different type of polarization, which is normal. That is how the collagen polarizes. So now let's look at this patient. You can see that you don't see the same patient. This is your normal, and compare the darker blues to it, you don't see something really abnormal in them. They look the same, even though the biomechanics was behaving differently. Now the question is, what is the real picture, is something which I will discuss here. This is the same kind of a confusion. One eye is completely different. Completely, the CBI is completely different. TBI is different. The biomechanics, the bad D is normal. In this other eye is completely normal. So these pictures makes us to believe that we don't need this machine because it's making confusing thing. Remember one thing, biomechanics is heavily dependent on the intraocular pressure. The left eye intraocular pressure is 18 millimeters of mercury. The right eye is 7 millimeters of mercury. When you have a eye which has a lesser IOP, you will have a lower biomechanics. When you have a more IOP, for some reason, there's a difference in that. That's something which the glaucoma people are looking at. And you have that the stronger IOP has a stronger biomechanics. It is a pseudo biomechanics, it's not a true picture. That means intraocular pressure determines everything in biomechanical measurement. And this is a very important take-home point I want to tell you. Without looking at the intraocular pressure, don't make it. And if the patient comes twice, and you're comparing the biomechanics, his IOP has to be same both the times. The case 4 is, again, one of the parameters is normal. The others are, there's multiple permutation and combination. So in this, you can see that the polarization OCT completely picked up the real picture. The CBI, which is your biomechanical parameters, completely way abnormal. Compared to the topography, so you can say that it was nearly normal, even though the TBI was on the green, and the PSOCT compared it with this kind of a blue, and you can see that there's complete absence of polarization properties, which means that the collagen is weaker. And look at the cornea; they don't look abnormal at all. And you do a LASIK on them, it's 100% ectasia, or you do a smile on them, faster ectasia than LASIK. LASIK takes a little longer time to develop ectasia. Again, going to the final truth, is the last case. The molecular markers will be the final truth. So every time we have this case, we take their epithelium or a smile lenticule, do a gene expression. Doing the gene expression, you'll exactly know how much of collagen, how much of lysyl oxidase, how much of all the factors are present. Because that is the only one which tells you which is telling you the truth. For example, in this case, your corneal biomechanics was completely abnormal. The topography was normal. So, and you can see that the polarization was abnormal, which means that when I took the epithelium of this, I did a PRK extra. When I took the epithelium of him, you can see that this patient had a very poor collagen and a very poor locks, which means that the biomechanics was telling the truth. We got confused because the topography was telling the opposite. It's telling it's normal. And your biomechanics was telling the truth. And the other eye, this is a different patient, but everything is normal. You can see that the collagen and locks, which is on this band, is completely normal. So biomechanics, there is a lot of truth in it, but it's a little confusing. It takes time, but just don't ignore it just because you feel that it's not worth to look for. The case 5 is, I'm just going to rush through it. This is one of those cases where you'd still get these kind of cases where everything is normal, but still the collagen is lower. So that is why you need collagen imaging for the future. I'll rush to this. This is a new software we are building. This is going to be part of Oculus. This is a completely AI-driven finite element modeling. It will tell you does not use the deformation. It uses the spring model concept That's why it's called newtons per meter. It will tell you before you do a surgery what is the predicted weakness in your cornea based on close to 1,000 odd patients across the world. And it has also a database of patients who develop it. And this is the nomogram where you can choose. You can take a screenshot later. And this is my team I work with.